Hello again. This is chapter 3. So let's take a look at some more heart failure. Let's take a look at the interdisciplinaries team role or interdisciplinaries team's role. Easy for me to say. So we just finished talking about diagnostic studies on the last slide. Let's get into interprofessional care. So the main treatment goals of the entire team is to treat underlying causes and contributing factors of that heart failure, to maximize that cardiac output. The better the cardiac output, the better chances we have with this person living a more healthy life. We're going to work to improve ventricular function. We're going to work to improve quality of life, and we're going to be preserving that target organ function. So like I said in the last one, when I was talking about cardiorenal failure, that cardiac output, that heart failure definitely impacts a lot of things, including target organs like the kidneys and the brain. We will be implementing oxygen therapy, which will help dyspnea and will help fatigue and make quality of life better. We will be starting to work with people or enhance their physical and emotional rest. The physical and emotional rest bundling activities so that they can conserve energy and decrease their oxygen needs. And then depending upon their level of severity is how much we do this. We also put together a structured exercise program. If we can put together cardiac rehab, CR, we have a lot better outcomes with people who are participating in cardiac rehab than people who are just trying to do self-management on their own and taking pamphlets home and may or may not be doing them. So there's some different heart failure drug therapy that we enact. We can use RAAS inhibitors. We've talked about these in some areas. We've also talked about them in pharm class. We've talked about ACE inhibitors. There's also angiotensin II receptor blockers. There's neprilysin angiotensin receptor inhibitors. There's aldosterone antagonists. The aldosterone antagonists tend to cause a person's potassium levels to spike. So we're going to be keeping a close eye on their K levels in their BMPs, in their metabolic profiles. We can use beta adrenergic blockers. We can carvedilol is a common one that we use with heart failure because it helps improve the contractility. It also helps a little bit with the blood pressure and that systemic vascular resistance that we were talking about when we were talking about hypertension. We use vasodilators like nitrates. We can use combination therapy. We can use digitalis, which is an inotropic agent. BT-dubs, digitalis has actually been a well-known thing that if you take too much of it, it kills you. So we want to make sure that they've got the right levels of digoxin, because too much digoxin is definitely fatal. Like all the way back to you can see it in Shakespeare when they're talking about foxglove. That's in those medieval times. That's what they're talking about. Then we can also look at implementing diuretics, and the diuretics help with edema. They help with venous pressure. They help with preload, that all of that blood flow that's coming up through the inferior vena cava and down from the superior vena cava. It promotes sodium and water excretion. We can use loop diuretics for that. We can use thiazide diuretics for that. But with this one, we also have to monitor the potassium levels, because when we're opening up those nephrons to have the everything goes sort of sale in terms of diuretics and diuresing, potassium will leak right out too. And so we want to make sure that they're not peeing off all their potassium when they're taking their diuretics. One of the other things that we can do is we can inhibit that sinus node. They have to be in sinus rhythm though, with a resting heart rate greater than 70 beats a minute, and taking every other sort of good medication. This is one of the last things that gets added to a medical regimen. And what it does is it decreases the heart rate But it does tend to decrease hospitalization rates for people with that heart failure with ejection fraction problems. So there are some other things that we can do in addition to medications. So we can implant some things. We can do an implantable cardioverter defibrillator, which is also known as an ICD or an AICD, you may have heard. That can, what that is it's literally a defibrillator that we put into their body, basically the same place that we would put their pacemaker. And if their heart stops beating, they have an internal defibrillator, and it shocks the heart and creates an electrical pattern again. We usually do not do an AICD for people with ejection fractions less than 20%, but when that heart failure is severe enough and you have an ejection fraction that's low enough, you get to make a decision as to whether you want to have an internal defibrillator placed or not. Another thing that we can do is we can do ventricular pacing, otherwise known as a pacemaker. This particular image shows a right ventricular pacer. You can have a biventricular pacer as well. So it not only does the right ventricle, but it also does the left. We can do remote monitoring as well. They can wear a Holter monitor, and that's an external thing. And it just kind of, they literally like put it on after they can't take a shower with it, but they put it on after the shower and they have it like on them, and it's take home telemetry basically. Here is that biventricular pacer. So here's the right atrial lead. You have that right ventricular lead, and then there's a left ventricular lead too, just for those of you who are really curious and wanted to have a visual about biventricular pacing. We will also be working with dietary for these people, and we're going to be really encouraging them to have a low sodium diet, and individualize those recommendations considering their cultural background. The American Heart Association website has really good dietary guidelines and great education for people who need to change their nutrition because of heart failure. Typically, the sodium will be restricted to 2 grams a day or a little bit less. Fluid restrictions for those late stage heart failure patients may happen. That 15, you may have seen a person on your clinical rotations that have a 1500 mil restriction or a 2000 mil restriction. What is really, really super important for these people is a daily weight. It needs to be at the same time, in the same clothing, every darn day. And they need to know what to do with that data. So we're not always going to be there to help them interpret the severity of the changes in their weight. If they have a weight gain of greater than 3 pounds in 2 days, or 3 to 5 pounds over a week, they need to come into the healthcare provider, and we need to take a look and see what we can change with their meds, or we can check to see what their adherence has been with their meds as well. So this is a huge team effort. This is nursing, or dietary, and primary care providers all working together to be able to help the patient get rid of fluid and stay healthy in that manner. So I'm gonna stop sharing again. And the next chapter is going to be what we do as nurses with people who have heart failure. So I will see you for the next chapter.